Thank you for viewing our webinar sponsored by Simon's VIP Connect titled Understanding Speech Sound Disorders, Is it Phonological Disorder or Apraxia? My name is Bethany Smith-Packard, one of the genetic counselors for Simon's VIP Connect, and I am joined by Marissa Mitchel, a speech-language pathologist at Geisinger Medical Center's Autism and Developmental Medicine Institute in Danville, Pennsylvania. During this presentation, Marissa will discuss pediatric speech sound disorders with an emphasis on phonological disorders and childhood apraxia of speech. Following the presentation, we invite you to submit any questions you have for Marissa by emailing the Simon's VIP Connect coordinator, and we'll show that contact information at the end of the presentation. Now it is my pleasure to introduce Marissa Mitchel. Marissa received her Master's of Science in Communication Sciences and Disorders from Penn State University in University Park, Pennsylvania. She is currently a clinical research speech-language pathologist at Geisinger's Autism and Developmental Medicine Institute. At the center, Marissa evaluates pediatric clients for a variety of speech and language disorders and makes recommendations about augmentative and alternative communication strategies for children with complex communication needs. Her research interests include describing the speech-language characteristics of known genetic disorders and designing effective interventions that are tailored to children's unique needs. Thank you for joining me, Marissa, and I'll let you go ahead and get started.
Great. Thanks for the introduction, Bethany. And thanks for inviting me to present this webinar. I'm going to talk to you today about speech sound disorders, and this is a common developmental problem in childhood, and it occurs even more frequently in children who have known genetic changes. So I'd like to begin by giving a brief overview of what will be covered in this webinar. To understand speech sound disorders, it's important to first know the basics of typical speech development in children. And there are quite a few types of speech sound disorders, but for the purposes of this presentation, I'm going to focus on phonological disorder and childhood apraxia of speech. I'll discuss the speech assessment process, including differential diagnosis, and then touch on intervention strategies, and finally, what's known about the prognosis for these disorders. I'd like to provide a brief background on typical speech sound development. So when you think about it, you realize that speech development actually begins before a child even speaks his or her first word. Right from birth, infants are able to attend to the speech of their caregivers, and then starting around 2 to 4 months, infants begin vocalizing by producing open vowel sounds, which is called cooing. By around 6 months, babies begin to babble. First, they repeat single syllables in what's called canonical or reduplicated babbling. And usually the first consonant sounds to develop at this stage are those that are produced with the lips and whole jaw. So those would be sounds like ba, 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 or ma, ma, ma. By 8 or 9 months, babbling becomes more complex and new consonant sounds are introduced. The months leading up to a child's first birthday are often filled with what's frequently called jargoning. And that's basically strings of syllables and nonsense words that are produced with adult-like phrasing and intonation. So it kind of sounds like the child is actually talking. And sometimes parents remark at this stage that it sounds like their babies are actually speaking a foreign language. The onset of first meaningful words then occurs right around 12 months. These figures demonstrate the anatomical changes that occur over the first few years of life. An infant's jaw and mouth are significantly smaller than an adult's, which you can see here, and so the tongue takes up a relatively large amount of space in the oral cavity. And this greatly restricts the range and precision of movement. And that's why the first consonants in vocal play and babbling are often the b and m sounds, which are produced by movement of the entire jaw and lips rather than the tongue. And then, as children's facial muscles and bone structure develop, they're able to produce a greater variety of sounds using multiple articulators and points of contact. So despite these changes over the first few years of life, certain sounds do continue to be more difficult to produce, and so they're typically produced later. So this graph provides a good visual representation of the sequence of speech sound development in the English language. So as I mentioned before, the first sounds to develop are those that don't require precise tongue movement and coordination. More difficult sounds are mastered later. So for instance, you can see at the age of 4, many typically developing kids continue to have difficulty with sounds like R, L, S, Z, and TH. And it's not uncommon for kids in kindergarten and actually even first grade to continue distorting these later developing sounds. Most kids do eventually produce sounds correctly on their own, but some kids might actually require direct intervention to do so. And it's the latter group of kids that demonstrate what's called a speech sound disorder. Speech sound disorder is actually an umbrella diagnosis that covers several specific different types of speech disorders, which I've listed here. So the first one is what's called an articulation disorder, and this occurs when a few sounds are distorted, but there's no detectable structural or physiological difference that could account for the sound errors. So kids who are otherwise intelligible but distort the R sound, or maybe they have a lisp, those kids would likely be diagnosed with an articulation disorder. These are kids who might say wabbit for rabbit or school for school. The next group is called structurally based speech sound disorders, and these are caused by frank changes in craniofacial anatomy. So for instance, a child might have a severe overbite that affects the way he says certain words. Kids with cleft palate aren't able to produce many consonant sounds, and children with macroglossia have a large tongue that actually impedes precise articulation. So these kids would have what's considered a structurally based speech sound disorder. Different from that is a phonological disorder, and this occurs when kids who have difficulty with the cognitive organization of speech sounds, they have difficulty putting these speech sounds into meaningful units. And I'm not going to go into detail about phonological disorder right now because I'll be talking more about that later in this webinar. Motor speech sound disorders are caused by deficits in motor planning and execution. They can be further broken down into the dysarthrias and apraxia of speech. So this webinar is going to focus on phonological disorder and childhood apraxia of speech. So first I'll talk about phonological disorder. And to really understand phonological disorders, it's important to understand the concept of phonemes. A phoneme is defined as the smallest unit of sound that carries meaning in a given language. For this reason, phonemes are sometimes referred to as the building blocks of language, and different languages have different phonemes. And phonemes can vary by place of articulation, manner of articulation, and voicing. The place of articulation refers to where in the mouth the sound is produced. So for instance, the initial sounds in pat and cat differ only in where they are formed. So p is produced by the lips, while k is produced by touching the back of the tongue to the roof of the mouth. Manner of articulation refers to the way in which contact is made. So the initial sounds in tell and sell, they don't differ in the place of articulation, but they do differ in how the airflow is disrupted. So t stops the air completely, while s allows the air to continue to flow. Lastly, voicing refers to whether or not the vocal cords vibrate when making the sound. So p and b differ only in terms of voicing. All hearing children need to learn which sounds are part of their native language inventory. In other words, kids need to learn which sounds carry meaning in their own language. Newborn infants actually begin life as universal listeners, meaning they can hear contrast between all sounds, not just the sounds of their own language. However, by about 1 year of age, children lose this ability to distinguish between all sounds. Instead, they've learned which contrasts carry meaning and which don't. They've learned to only pay attention to phonemic contrasts that are important in learning their native language. And at this point, they've started to understand and develop a rule-based sound system that's unique to their own language. And this rule system is called phonology. So what is phonology? It refers to the sound system of a language and includes the cognitive organization of speech sounds into phonemic categories, as well as the rules that govern sound combinations. And these are specific to a given language. So even though the rules are unique to different languages, they can also be specific to a given child. And this type of phonology is referred to as child phonology. And there's a sequence of what's considered normal child phonology. As children develop language, they often employ certain rules that dictate how phonemes are categorized and produced. These rules, which are called phonological processes, often simplify speech sounds. And phonological processes might change a phoneme's voicing, it might change the place of articulation or the manner of articulation. So for example, the phonological process of fronting means that a child substitutes sounds that are produced in the back of the mouth, like k and g, they substitute those with sounds that are produced in the front of the mouth. So they'd say tuh or duh. And this changes the place of articulation. The process of stopping, on the other hand, actually changes the manner of articulation. So for instance, fricative sounds, which are those where the air continues to be pushed out between the tongue and the teeth, which would be s and z. Those are instead stopped and produced as tuh and duh. Other processes actually take out consonant sounds or even entire syllables, making words easier to say. And each of these phonological processes is actually normal up to a certain age. But if a child uses them past the expected age, they might demonstrate what's called a phonological disorder. So what is a phonological disorder? It's the use of immature or unusual phonological processes. In other words, you could say disordered rules govern a child's speech. And you can think of it as a higher order linguistic deficit, so there aren't any deficits in the structure or functioning of the articulators themselves. So there's nothing wrong with the tongue or the jaw muscles or the palate, and there's nothing wrong with motor planning or programming. Instead, the problem lies in the cognitive perception and organization of speech sounds. As I mentioned, children with phonological disorders can demonstrate two types of disordered speech rules. First, they might employ a normal phonological process past the age when we would expect the child to grow out of it. So an example of that would be a child who says tat for cat at the age of 4. This process, which is called fronting, is actually normal for a young child who's age 3, but it really should be discontinued by the time a child's 4. Another type of disordered phonology would be when a child uses a phonological process that's unusual and not typically seen in normal phonological development. So an example of that would be the process of backing, and that's where sounds produced in the front of the mouth are replaced by sounds in the back of the mouth. So for instance, a child who says ken instead of ten. And this is a process that typically developing kids don't tend to use. So it serves as kind of a red flag that phonological development may actually be disordered. So how common is phonological disorder? Many people aren't familiar with the term phonological disorder, so you might actually be surprised to learn that it's one of the most common developmental problems of early childhood. And in fact, 7.5% of all 3 to 11-year-old children demonstrate the disorder with varying levels of severity. Like many other developmental disorders, boys are disproportionately affected compared to girls, so boys outnumber girls about 3 to 1. And one study found that over half of all kids with a phonological disorder also demonstrated some degree of expressive language impairment, and a subset of those kids had difficulties with language comprehension as well. So I think the best way to conceptualize a phonological disorder is to actually examine a child's speech production. So take a look at this speech sample from Riley. Riley's a 4-year-old boy who has a moderate phonological disorder, and his speech sound errors are actually some of the most common that we see in young kids. So if you look at that speech sample, you can see that he says tap to mean the words cap, sap, and trap. And I want you to remember this point because we'll come back to it when we talk about treatment for phonological disorders. He also says do for go, do for zoo, met for mess, boo for blue, Dean for green, Nana for banana, and Bella for umbrella. So what's going on here? If you remember those list of phonological processes that we just went over, we can actually use those processes to decode Riley's speech and see that there's actually a pattern to his sound errors. So taking a look at some of those phonological processes, we'll apply those to his speech sample. So for instance, he says he uses the phonological process of fronting, which are when consonants produced in the back of the mouth are actually produced in the front. So some examples of that in Riley's speech would be him saying tap to mean cap or saying do to mean go. He also uses the phonological process of stopping, and that's where fricative sounds, which in this case are S and Z, are replaced with stop consonants, which would be T and D. So examples that Riley says would be met for mess and do for zoo. He uses the rule of cluster reduction, and that's when, in his speech, if there's more than one consonant in a row, he's deleting the second consonant altogether. So examples of that would be him saying boo for blue or tap for trap. And the last rule that he's using is what's called weak syllable deletion, and that's where unstressed syllables are deleted when the word has 3 or more syllables. And examples of that would be nana for banana and bella for umbrella. So a key point about phonological disorders is that we can make predictions about how a child would pronounce a given word, as long as we understand that his or her unique rule system applies. So to illustrate that point, let's consider how Riley would pronounce the word crazy. So if you look at this chart, on the left-hand side, we can look at a list of his phonological rules, and those can be systematically applied to the target word. So let's take a look at crazy. If we apply cluster reduction, then the word would become casey. If we use fronting, then we would say tazy, because that k becomes the t sound. And lastly, Riley would use stopping, so that z would become a d. So in Riley's case, we would predict that he would pronounce crazy as tatey. And his pronunciation would be the same each time he says that word, and it shouldn't matter what the context is. And this is an important point because it's one of the things that sets phonological disorder apart from other speech sound disorders, especially childhood apraxia of speech. So I'm going to transition now away from phonological disorders and talk instead about childhood apraxia of speech. And it's been known and really continues to be known by several different labels. So you can see here developmental verbal dyspraxia, verbal apraxia, developmental apraxia of speech, speech dyspraxia, and these are all different terms for the same disorder. They actually mean the same thing. Developmental verbal dyspraxia tends to be the term that's still used in the UK, and developmental apraxia of speech was historically the term used in the US until quite recently. And the American Speech-Language Hearing Association decided to drop the term developmental and replace it with childhood for a few reasons. So first, the word developmental suggests that it's a normal problem that occurs in childhood and will resolve on its own without any direct intervention. And that might be an erroneous assumption. Secondly, developmental also suggests that it's a congenital problem that's with a child from birth. So it doesn't leave open the possibility that apraxia might be the result of postnatal injury or insult. And lastly, the word developmental sometimes leads to problems with insurance reimbursement for therapy and other services. So for all of these reasons, the correct terminology to use in the US is childhood apraxia of speech, or CAS for short. So what is childhood apraxia of speech? This seems like it should be an easy question to answer, but the truth is that there continues to be a good deal of disagreement and controversy surrounding the diagnosis, even among speech pathologists. So to address this issue, the American Speech-Language Hearing Association, or ASHA, organized a committee to develop a technical report on childhood apraxia of speech. And their goal was to summarize what's known about the etiology, diagnosis, intervention, and treatment of the disorder, and also to better define it. So the official definition that ASHA came out with is that CAS is a neurological childhood speech sound disorder in which the precision and consistency of movements underlying speech are impaired in the absence of motor deficits. And the core impairment in planning and or programming spatiotemporal parameters of movement sequences results in errors in speech sound production and prosody. Now I think that's a pretty wordy definition, so an easier way to think of apraxia is that it's a neurological disorder that affects motor planning and programming. I think an equally important question to answer is what isn't childhood apraxia of speech? And first, a common misconception is that childhood apraxia of speech is a term to mean a very severe speech sound disorder. And this isn't the case. It's not simply an indicator of severity of impairment. And in fact, severe phonological disorders can result in worse intelligibility. Like other speech sound disorders, childhood apraxia of speech can actually range from mild to severe. It's also not caused by motor deficits, such as low muscle tone or muscle weakness, and that's actually inherent in the definition of CAS. If there are persistent motor deficits, then the correct diagnosis would probably be dysarthria. Lastly, it's not the same thing as developmental coordination disorder, or dyspraxia as it's known in the UK and elsewhere. So like CAS, developmental coordination disorder is a neurological disorder that affects motor planning, but its effect is more global. It affects multiple body systems, whereas a diagnosis of CAS means a child's volitional movements of the articulators are what are specifically affected. However, CAS can occur within the context of a more global developmental coordination disorder. So how common is CAS? The short answer is it's really not common at all. So one research group estimated its prevalence at only about 1 to 2 children per 1,000. That might be an overestimate, or rather an underestimate, but it's clear that CAS is quite rare. Compare that estimate to the prevalence rate of phonological disorders among young kids, which, if you remember, is about 7.5% of all children ages 3 to 11. Another group looked at all speech referrals to a major metropolitan area during a 6-year period, and they determined that approximately 3 to 4% of children with speech delay would go on to receive a diagnosis of childhood apraxia of speech. So while there are differences in prevalence estimates, I think most researchers in this area do agree that CAS is overdiagnosed at present. And contributing to this overdiagnosis is probably the fact that there continues to be disagreement about what characteristics or symptoms we should look for when making the diagnosis of apraxia. And I'm going to discuss the evaluation process and differential diagnosis in more detail a bit later in this webinar. So what causes apraxia? Well, for most children, apraxia is idiopathic, which means that we don't currently know, that we aren't able to determine an exact cause at this point. And brain imaging typically won't show any obvious structural or functional abnormalities. Even though we don't know the exact reason that apraxia occurs, many experts believe that there is an underlying genetic etiology for most cases. And in fact, there are some known genetic and metabolic syndromes that are associated with increased rates of apraxia in children. Probably the most well-known genetic cause of apraxia is a mutation in the FOXP2 gene, and a large family in the UK was studied for several years and actually continues to be studied, and it was found that virtually all family members with this mutation demonstrated apraxia of speech. However, FOXP2 mutations are incredibly rare, and so they probably don't explain most cases of apraxia. Galactosemia, on the other hand, is a genetically caused metabolic disorder that's associated with a greatly increased risk for CAS. So one study found that about 20% of all children with the condition demonstrate apraxia, and that's much higher than that estimated population prevalence, which was only about 0.01%. And lastly, there was a recent case report in the European Journal of Human Genetics that described childhood apraxia of speech in 2 children who had a known 16p11.2 microdeletion. And the researchers there hypothesized that apraxia might be more common among kids with this microdeletion. Although I think a lot more research does need to be done in this area before we can make any strong conclusions. So the diagnostic assessment process should be carried out by the speech pathologist, and that's because speech pathologists are the professionals who are probably the most qualified to evaluate children with speech sound disorders and ultimately make the differential diagnosis of phonological disorder versus childhood apraxia of speech. And unfortunately, there's no single valid and reliable test that's going to tell you whether or not a child has apraxia or a phonological disorder. Rather, the speech pathologist will assess multiple areas of speech and language through a combination of direct standardized and non-standardized tests. They'll probably also take language samples, conduct an observation, do a parent interview, and do other measures as well. And the SLP looks at the entire constellation of features to arrive at the diagnosis in the end. And importantly, speech sound disorders can't be diagnosed reliably if a child presents with a severe expressive language delay. That's because there needs to be enough expressive language to provide a representative speech sample. So speech therapists might suspect apraxia in kids who are minimally verbal, but in that case, the most they'd be able to say would be suspected childhood apraxia of speech, or they could make a note to rule out childhood apraxia of speech as expressive language develops. So one major goal of the speech evaluation is to make a differential diagnosis between speech sound disorders. And this can be difficult, even for experts, because there aren't any universally agreed upon or empirically validated characteristics that are unique to childhood apraxia of speech. And there's actually a significant amount of overlap in features of both disorders. So the goal is to decide whether a child's unique constellation of symptoms is most consistent with one speech sound disorder over another. So looking at this chart here, you can see that poor intelligibility, multiple sound errors, no structural changes or muscle weakness, those are all common to both phonological disorder and childhood apraxia of speech. Both are also linked to a higher likelihood of comorbid language deficit. So if you see any of those characteristics during the speech evaluation, you really can't make a conclusion one way or the other because it's common to both disorders. However, one thing that's pretty unique about childhood apraxia of speech are that you might see errors that are inconsistent in repeated productions of the same word. With phonological disorder, on the other hand, you might hear a lot of sound errors, but if you remember, those errors are rule-based and predictable. So looking back at Riley, we could predict how he would say the word crazy simply by knowing that the rules that he's employing in his speech. It's really difficult to figure out any consistent rule when a child has childhood apraxia of speech. Another difference in apraxia is that transitions between sounds are lengthened and disrupted. So speech is going to sound effortful and choppy. It might be a slow rate of speech. With phonological disorder, you're going to hear normal transitions between sounds. So that's another difference between the two. In apraxia, you're also going to hear unusual prosody and irregular stress patterns. So a child might say banana instead of banana. Whereas in phonological disorder, you're going to hear the normal stress patterns, normal prosody. So even though there are speech sound errors, the rate of speech is going to be more normal. It's going to sound pretty normal. Stress patterns are going to be normal. In apraxia, you might hear some vowel distortions, whereas in phonological disorder, almost all the speech sound errors are going to be with consonants. You might hear a few vowel distortions, but that's going to be relatively uncommon. And lastly, with apraxia, you might hear intermittent hypernasality, and that's because there's going to be some coordination issues with the velopharyngeal port, whereas in phonological disorder, hearing resonance issues is going to be pretty unlikely. So those are some differences that speech pathologists are going to listen for during that assessment process. Moving on to intervention, for both phonological disorder and apraxia, speech therapy is warranted when a child's speech sound errors affect his or her ability to be understood by others. And the ultimate goal of therapy for both disorders is to minimize speech sound errors and improve speech intelligibility. However, speech therapy might vary in terms of its focus, its methods, and its frequency, depending on the child's diagnosis. And I'm going to highlight that in more detail in just a moment. I do want to emphasize here, though, that speech therapy that focuses on producing sounds correctly is the only intervention that's been found to be effective. So there are other treatments that are sometimes encountered, but these are not supported by research, and these would include things such as vitamins and supplements, and also non-speech oral motor activities. Oral motor exercises would include things like blowing through whistles or straws or chewing on plastic tubes to strengthen the oral musculature. And at this point, there's quite a bit of research that indicates that these methods are ineffective in treating speech sound disorders, so they should be avoided. Looking at phonological disorder, as I mentioned before, speech therapy is recommended for both disorders when the sound errors impede intelligibility, but the approach used is going to be different depending on the child's diagnosis. So with phonological disorders, kids often lose phonemic contrast. So you might recall that phonemes are the smallest units of sound that carry meaning, and kids with phonological disorders often produce different words the same way because they don't adequately differentiate between phonemes. To give an example, looking back at Riley, you might remember that he employed several phonological processes in his speech. The end result was that he substituted the same sound for multiple different phonemes, which means that he doesn't distinguish between words that contain these sounds. So if you remember with Riley, he said tap to mean both tap, sap, cap, and trap. So all of those contrasts were actually collapsed into one sound, which is just the T sound. Therefore, therapy for kids with phonological disorders actually targets this lack of contrast between sounds, and it emphasizes that a child's sound errors actually change the meaning of words. So the goal would be to get Riley to realize that by substituting that T sound for all these different sounds, he's actually changing the meaning of words. So two therapy methods that might be appropriate for a child like that would be minimal pair therapy and multiple oppositions. And both of these strategies highlight phonemic contrast between similar sounding words. Moving on to intervention with apraxia. Apraxia is thought to be a disorder of motor planning and programming, so the focus of therapy is often on practicing the motor sequences that are required for speech. So this type of therapy typically involves extensive repetition of different consonant and vowel combinations at both the syllable and word level. The goal of therapy is to make speech motor sequences automatic and rote. So that's similar to the over-practicing that's required to learn how to play the piano or type on a keyboard without looking down. And clinical wisdom is that therapy for apraxia should be more frequent than therapy for other types of speech sound disorders. And this idea makes sense when you think of what we know about motor learning in general. However, at this point, there's really limited research looking at what the ideal amount of therapy would be in terms of outcomes. As a result, there's no widely agreed upon guidelines for frequency of intervention. There are several different specific therapy programs designed for childhood apraxia of speech, but at this point there's little empirical support for any specific curriculum. There clearly needs to be more research in the area of treatment efficacy in general. So the therapies that I've discussed up to this point all focus on verbal speech, but another type of intervention that I think should be considered simultaneously is augmentative and alternative communication, which is called AAC for short. And AAC includes all strategies and tools that are used to supplement a child's speech so that he or she can communicate more effectively. So some examples of AAC would be sign language, picture exchange, and high-tech communication devices, which would include the iPad. And these strategies, I think, should be considered whenever a child's speech is really difficult for others to understand. And research shows that AAC will not prevent a child from learning how to talk, but it will help alleviate some of the frustration that often arises because a child has a difficult time communicating. So one thing that I'm often asked by parents is what the prognosis is for different speech sound disorders. And there definitely needs to be more research in this area, but we can make some conclusions. So studies show that kids with both phonological disorders and childhood apraxia of speech are at risk for learning difficulties later on. And those would be things like language learning disabilities and dyslexia. So for this reason, it's important that young kids with speech sound disorders are provided with phonological awareness and pre-literacy training from an early age. You also want to monitor closely the kids as they begin school to make sure that they don't develop any reading problems. And in general, the earlier the intervention, the better the outcome. And this is true for developmental disorders, for all developmental disorders really, and speech sound disorders aren't any exception. Parents often want to know if their child will ever develop normal speech. And many children do go on to develop speech that is indistinguishable from that of others who have never experienced difficulties as kids. But there are some kids that might continue to demonstrate some mild residual speech differences into adulthood, and a small group of kids might require the use of AAC throughout their lives. So it's impossible to predict with certainty whether or not a child will go on to develop what is considered normal speech. But in general, a child's prognosis is going to depend on how severe the speech sound disorder is and whether or not there are any significant comorbid conditions that might interfere with treatment efficacy. So a child who responds more quickly and dramatically to early speech therapy would likely make more rapid progress and therefore have a more favorable diagnosis. So as I mentioned, there's clearly a need for more research into treatment efficacy and long-term outcomes. So I want to direct you to a few online resources that I think are really informative and helpful. The first one is a website by Carolyn Bowen, who's a speech therapist, I think, located in Australia, and that's called Children's Speech Sound Disorders. You can go ahead and take a look at speechlanguagetherapy.com. There's some great resources both on phonological disorders, apraxia of speech, dysarthria. The American Speech Language Hearing Association is another really good resource. And lastly, the Childhood Apraxia of Speech Association of North America has some great resources both for families and also for speech therapists and teachers about apraxia. So that concludes my webinar. Thank you very much for joining me.
Thank you, Marissa, for a great webinar, and thanks to everyone for viewing the presentation. Please remember to submit any questions for Marissa to the email shown here, coordinator@simonsvipconnect.org. Answers will be posted on the website later on. Thank you.